Uh, there's a good news and there's a bad news. The good news is this case will never be given to you in the exam. And the bad news is that you will still have to hear the discussion. Okay. But I feel it is very, very important for trainees in plagiocephaly to understand something about craniosynostosis. Because if you don't know about it, this field is going to be taken over by our friends. And we have many friends. Major official surgeons will just run over you. So it is very, very important that you should have a working knowledge of these deformities. And if possible, you should be capable of doing these procedures. Now, you know, we all know that when a newborn is child is newborn, there are many of these sutures present in the skull. The purpose is to allow the rapid growth of underlying brain so that it gets accommodated inside the skull. Okay. Now, if because of some reason these sutures get prematurely closed, you will call it craniosynostosis. You know, so either one or all suture could be affected. Now, so these are the different views of the infant skull, and you know that there are many sutures in the frontal region, the metopic suture, the coronal suture, the lambdoid suture, the sagittal sutures, and which suture gets fused will lead to a deformity which can be explained on the basis of the growth which is taking place in the skull. Okay, so today we will concentrate on what happens if one side coronal suture is fused. Now, let us say this is our infant skull, and the suture on one side, the coronal suture on one side is fused. Now, what is going to happen? The skull on the side where it is fused will not grow. So that means the skull on the side where the suture is fused will be flatter. The frontal bone on that side will be flatter. It will be little higher up also. So this is how it will look like. Now, when it is happening, you will also notice, because the coronal suture is not growing, the orbit which should be growing is also not growing. That means there is deficiency of bone in this region. The bone should have been like that. Since there is deficiency of bone, so the orbit, instead of being almost circular, becomes like an oval thing. It is vertically oriented. This is known as Harlequin sign. This is because the bone is not being laid here. As a result, the forehead is flat and the orbit is vertical in shape. This is how it will look like. So if you look from the side, this skull, if the coronal suture is not growing on that side, you will find that the height of the forehead on that side will be less as compared to the other side, and this is how it will look like. Right? So, in a plagiocephaly, we will have a situation in which the forehead on that side is at a higher level, it is flatter, the orbit is vertical, and when you see from the side, the forehead from that side is flat. So this is how the child with a frontal plagiocephaly will look like. You find that the forehead on this side is flat, and the palpebral aperture on this side, affected side, is smaller than the palpebral aperture on the other side because of the reasons I explained. And you will find that even the supraorbital margin is at a different level. You will also notice that the nose root, look at the root of the nose and look at the tip of the nose. The tip of the nose is pulled towards the normal side, and the root of the nose is diverted towards the affected side, because on that side the root of the nose is not growing, so it is different here. And you will also find that on the affected side, the ear appears to be a little more anterior as compared to the ear on this side. This is because there is deficiency of bone, so it gets more anterior. So, likewise, the chin will also show little slight deviation towards the normal side, because on this side it is growing, on this side it is not growing, proportionately. This needs to be, all these points which I told need to be very carefully noted, because there could be a situation in which the children can have deformity of the skull because of position of the skull. You know that when these children are small, their bones are moldable. So if they continue to lie on one side, chances are that that part of the skull will become flat. This is known as positional plagiocephaly. So if the child was lying on one side, you will notice that even the forehead on that side, see if it is flat on this side, the child's forehead on this side will become flat. Okay? Now, but here you will find, and it is absolutely normal, you change the position of the child to the other side, this will correct. How do you differentiate this? This you differentiate by looking at 2-3 key points. One is, when you look at the nose is absolutely right in shape. Okay? Then, although it is not seen in this child, the level of the ears will also be same. You will find that the chin is also in the midline, and the size of the palpebral puncture on both sides will be same. So it is important. Otherwise, you don't panic looking at every child who has slightly depressed forehead. Look at the occipital area. Is it flat? And look at the size of the palpebral puncture. If it is same on both sides, don't have to worry. And the best is get the radiology done. Look at the CT scans. If the CT scans show you that the sutures are normally present, really you don't need to do anything. And these are the points which I just explained to you. Why does a particular feature appear this way in plagiocephaly, and why does it happen this way in a positional plagiocephaly? Since in plagiocephaly only one side coronal suture is involved, so chances of these patients having raised intracranial pressure will not be there. This slide is just to explain that in all cases of craniosynostosis, about 5% cases might have raised ICP. But this particular slide does not apply to the plagiocephaly, because everything else is normal. All the other sutures are normal. Okay, so then what is the need for surgery in these patients? We have to understand very clearly that this is only for aesthetic reasons. If you don't operate on these children, what is going to happen? The forehead will continue to be slightly depressed, and since the eye level is also slightly different, these children have a tendency to keep their eyes squinted. So they might develop exophorias, there might be development of squints, and these children also have a tendency to turn their neck to compensate. So they might develop torticollis. So all these things could lead to further compounding of the aesthetic problem. Alright, so the need for surgery is primarily aesthetic, but also to some degree functional, provided these things are present. And the squint and torticollis will be present if the child has very severe deformity. When should this surgery be done? This surgery should be done during infancy, because if it is to be done for cosmetic reasons, let the child grow with normal body image. And not only that, it also allows for brain to grow maximally during the time when it is growing fastest. Right? And for surgeon, the surgery is easy because the bones of the children are flexible, elastic, moldable. So you can give them the shape you want. As the child grows older, this becomes more difficult to mold the skull. So this I would explain when I said that, when I say that moldability, this is the part of the skull and the orbit bones in a small child, where you can see that this can be molded the way you want. So what will be the principle of management? You know that on one side there is restriction of the skull volume. So we should remove that restriction and try to increase the volume of the skull on that side, so that now the brain has an opportunity to grow onto that side also normally. And since there is on one side the forehead is it's flatter, the size of the orbit is different. So all those things also need to be corrected if you want to have a good cosmetic image. Right? And you would have also appreciated that it is not only the frontal bone, it is part of the roof of the orbit, which is also having restricted growth. So you need to address the orbital segment, not only the frontal bone, you need to address the orbital segment also. So that is why you need to address the fronto-orbital segment. You need to advance it from there. Okay? So this is what you want to do in a case of plagiocephaly. Now, in this patient, you will notice that on this side, she has got plagiocephaly, and in fact, these fused suture on this side can be felt through this scalp. You know, through this scalp, you can feel it because it is solid bone there. And when you open it, you will find that the suture on this side is fused, on this side the suture is intact. And when you take out this part of the skull along with part of the orbit, you find that this is the normal side, and this side has recessed by this much degree. It is flatter. So you need to bring it out. Right? So this was done in this patient, and maybe 6 months later she looks like this. And when she became 10 years of age, you find that the correction which was done at the age when she was about 6 months to 9 months old has continued. But you look carefully, you will still find that the orbit size is still not matching. And the nose is, although looks grossly normal, but if you see carefully, there is slight deviation of the root of the nose still present. So, although you have corrected the deformity at childhood, many of these children will continue to have that effect even into the adult life. So you might need to do some kind of touch-ups later on also. So this also just to show you how we can correct these deformities. Now in this patient, you know that there is a plagiocephaly on this side. So what we have done, this is the coronal incision has been done, and this is how you look at this skull on the table. So this whole segment of the bone has been taken out. Then we take out this part of the orbital, sphero-orbital margin, lateral orbital wall, and roof of the orbit, which you can see it here. This is that fronto-orbital segment. And you know that this fronto-orbital segment on this side was flat. So what we have done, we have taken bone graft from this skull and placed this as an onlay graft, so that the breast part is elevated now. And you will also notice that on this side, I have opened up the orbit, so that the orbit is now more longish than this height-wise. So this correction has been done, and then you put it back. And this is how they will look in the post-operative period. I think this is about 3 or 4 years post-surgery. But if you are careful, you will again find that there is still mismatch in the size of the orbit. It can be very difficult to correct in many people. Or, you know, sometimes these could be so extreme. In this patient, you can see that there is so much of deviation of the nose, deviation of the chin, flat, the forehead is flat, and not only the orbit is smaller in aperture, is smaller in size, it also is at a lower level as compared to this side. So there is orbital dystropia, there is deformity of the forehead. So all these things can be corrected in one stage. They can be done, like we had done in this patient. And what we did, this is the part of the frontal bone which has been taken out. This is part of the fronto-orbital segment. And we have also taken part of the deviated nose, the nasal bones, along with this segment. And then, since this was being done in a child when the child was very small, we have given these vertical scorings in the bone so that now it can be molded, it can be made more curved. And then you made corrective osteotomies in the nose also. And then you put it back. And then this is how she looks in the post-operative period. Not very good result, because it is very difficult to achieve good results in such extreme cases. But if you compare it with the pre-operative, it's reasonably okay. So, in conclusion, plagiocephaly is a craniofacial deformity which needs to be corrected only for aesthetic reasons. And the best results can be achieved when you do it at the earliest, and sometimes you might have to go in and do small touch-up procedures when the child grows up. And, but in some cases, even one surgery might be good enough. And it is also very important that you differentiate whether it is a true plagiocephaly or it is position.
I think the bad news is that from now onwards it will be kept in exam.
I don't know. I don't know. Because I will not, if I am an examiner, I will not keep this as a case. Because I feel that unless you have adequate exposure, this should not be kept as a standard case for the exam.
At least in the PGI exams.
Okay.
You tell us which questions we have to ask. We don't know anything.
I will thank the organizers for giving me the opportunity to make them, aware of the plagiocephaly. That's all I can say. You have to understand that there was an editorial in PRS about a couple of years ago, and there it had said that all plastic surgeons should know, at least every plastic surgeon should know 5 procedures before they can be given the degree. And one of the procedures was how to raise a coronal flap and how to harvest cranial bone graft. This was one of those 5 procedures. Okay, so it is very, very important for all the plastic surgery trainees to have a working knowledge of this very important field. Otherwise, I'm afraid this is going to be hijacked by our sister specialties, and I think it is.
Show us the first slide, the skull. Okay. First slide, which has that skull.
First. Okay, I can do it from here.
That one. First slide. Yeah.
No, just
now I think
just click it. I will do it.
You can explain to them, if one side corneal is fused, then it is plagiocephaly. At least tell them what are the fusions, others which lead to other deformities.
No, it's a big lecture explaining. Now you can see if it is only on one side. If it is on one side, then we had seen the effects that there is a restricted growth on one side. So the forehead on that side gets restricted. Suppose it is on both sides, then what is happening is this size of the skull, anterior-posterior, becomes small. If sagittal suture is fused, then what is happening? There is no growth taking place parallel to the sagittal suture. Everything is happening in the coronal plane. So the skull will become long and narrow, what you call as scaphocephaly. Now, if the suture in the forehead region, in the frontal bones, is fused, then what happens is it becomes like a wedge. It becomes like a trigonocephaly. It's like a triangle. So that is metopic synostosis. So metopic synostosis will mean that the forehead is like a triangle here, and both the eyes will be very close to each other. That is known as trigonocephaly. Brachycephaly, when both the coronal sutures are fused, now the growth of the skull is taking only along the sagittal plane. So the skull will become short anterior-posteriorly and it will be broad. Okay. In sagittal synostosis, the growth of the skull is now along the coronal suture only. So the skull becomes long and narrow. So I think that's the basic issue. Yes.
In one of your slides, you have fixed the bone with the titanium screws. Is it advisable to fix with the non-absorbable material?
Ideally speaking, no. But for quite some time now in India, the absorbable system is not available. It was available a couple of years ago. Right now, there is only one company which is providing it, and it is exorbitantly costly. So, since the absorbable materials are not available now, so you must have noted that I have not used the plates. I just used a screw, just one screw, so that it does not lead to restriction of the growth. But your point is very well taken. In a growing skeleton, we should not use metal hardware. Yeah, now we have absorbable plates and screws available.
What age do you ideally suggest these procedures?
As I said that, see, when we talk of plagiocephaly, it is primarily an aesthetic procedure. So I would like to do it not at the age of 3 months. I would like to do it when the child is say 9 months to 1 year. The child is physiologically more stable. They can withstand the stress of surgery. The tissues are more manageable. And the child has not developed that body image concept by that time. So if you do it by say 1 year of age, it should be good enough. I don't want to delay it even further because then the moldability of the skull is an issue. You know, it becomes more ossified. It's very difficult to shape it. So the compromise will be 9 months to 1 year. You should be able to do it. But there could be situations when multiple sutures are involved. Then you might have to go in and do it early because there could be raised intracranial pressures. The eyes could be proptotic. There could be exposure keratitis. So in those situations, you have to do it at the earliest. Yes, efforts improved. Yes.
So the thing is, we are dealing with a syndromic plagiocephaly. How the age time is
No, that's what I said. That in syndromic, the synostosis is rarely single suture. It is multiple suture involvement is there. And in those patients, apart from the bizarre shape of the skull, there is proptosis of the eyes also. So that means the eyes are being pushed out. So it becomes kind of imperative that you go in and increase the capacity of the skull so that the brain, the growing brain can be accommodated and the popping eyes are pushed back. So it is kind of semi-urgency. You will like to operate upon these children between 4 months to 9 months or so, or whenever it is possible for you to do it.
But Nelligan has written that in syndromic we should intervene in between 4 to 5 years. Reason they have given that the frontal sinus maturity.
I don't know, maybe you have read it correctly or not. It could be with reference to something else they are saying. See, the reason for operation in these children, in syndromic children, or say non-syndromic children, is that you want to increase the capacity of the skull. That is paramount importance. In these children, you don't have the ventricles which are blocked, and that's why there is proptosis. No, it is because the capacity of the cranium is very small. If you wait for 5 years, the brain will not be allowed to grow for 5 years. I think there must be something else before what you have read. You need to do the intervention early, and you must understand that they will require interventions more than once. But it has to be early. There is no doubt about it. If you wait for 4 years, the child would have lost the vision. There will be pressure effects. In fact, the syndromic children, there are many other problems also. They have problems with their breathing, their airway is not good. So when you are doing these surgeries, it helps improve everything.
Thank you, sir. Thank you very much. Now,